paying a cost that would adversely affect you or tilt you into poverty. That is what the bigger box illustrates. The smaller box you see there illustrates the journey of different countries. This is a sample country, and it shows you what countries can do in different dimensions of coverage or different dimension of financing in order to achieve the journey towards covering the whole of this cube. That small yellow cube covering the whole of this bigger cube is the journey towards universal health coverage. And different countries can do it in different dimensions. You will see the x-axis. It shows population and the question, who is it that is covered? So that population, that axis denotes such things as covering pregnant women, antenatal care, under 5 children. So a country can decide that they want to cover everybody. And so that cube will extend all the way and cover the whole of the x-axis. But you must remember that it is a choice and it has a cost. And therefore, if you are... Hello?
Apologies, are you able to put your slide on slideshow so that it will be more visible? And if possible, use your cursor to describe as a pointer, so we're able to follow you through. Thank you.
Oh, can you see my cursor?
Yes, we can now.
All right. So I was just explaining this cube, and I had explained that this entire cube denotes that perfect society where people get healthcare that they need, very good quality healthcare at a cost that they can afford. And I just started describing this first dimension. That is the x-axis of this cube. This x-axis denotes the number of people covered. Okay, that means everybody. So here you see it stops here, and you can assume that from the beginning here to here can be such things as maybe women and children and the 5 vulnerable groups, right? So this other group that is not covered, they are not covered because there's a question around amount of money you have to be able to extend coverage to the whole of the population. Not every country, in fact, there is no country that is able to do that. There's always a trade-off. Either, so for instance, you can say that your mechanism in your country will provide malaria coverage for everybody. So this cube will then extend all the way down here, but you're only providing malaria treatments. There are so many other things that are missing, right? And those things that are missing would be illustrated here in this other axis. This axis is called the z-axis. The z-axis. The z-axis describes the services you are providing in your coverage. So if you're providing only malaria services, your cube will look something like from here to this place. Only malaria. So all the other things, HIV, TB, hypertension, non-communicable diseases, immunization services will all not be covered. So your box will be very thin here, but then because you're covering everybody for malaria, it would extend to this point. The other thing about this cube is that it describes cost sharing. Cost sharing, how much are people paying for these services? Is it free to them or do they have to pay a fee? All right. So these all give us something on this cost sharing axis, which I have to speak about, is financial protection. What do people have to pay out of pocket? So the goal of every health system and the financing of every health system is to reduce what people have to pay out of pocket, increase the number of services available to them, and expand the number of people that are covered. There are different mechanisms to be able to do this. It can be health insurance. It can be financed from tax pool. It can just be a facility-based sort of coverage where the government is paying for everything. You don't even have to enroll for any insurance. You just need to show up in a facility and you get care. In Nigeria, we'll have a mixed model of a number of those things. So that is the goal of every health financing scheme, everything that we do in countries. Now, the picture of Nigeria. Here in Nigeria, in the current administration, we're all familiar with what I'm showing on the screen. It is a strategic vision of the health sector laid out over from 2023 to 2026. And the goal mirrors what I had just shown to you: to save lives, reduce both physical and financial pain, produce health for all Nigerians. However, it has identified pillars and strategic areas it wants to focus in trying to accelerate the progress towards universal health coverage. And it recognizes that these pillars are important to then work and achieve those dimensions that I showed to you. So everything here basically tries to contribute towards achieving those dimensions. You're familiar with this, so I'm not going to spend a lot of time on it. And this is also in speaking to the landscape that is evolving for health financing in the country. So the focus are on these 9 issues that we have identified over the years as the biggest problems for our very poor indices. And that is why the sector renewal project focuses on them. You're also familiar with the broader Nigeria Health Sector Renewal Investment Program that basically has 2 components. A revitalized basic healthcare provision fund that is now supposed to be a basic healthcare provision program. And then the industrialization fund that focuses on the investment side of things and the value chain support systems. Now, there are within the basic healthcare provision programs, such things, innovative financing mechanisms as decentralized financing, where monies go all the way to facilities for them to determine how flexibly they can use it and not being tied to budget lines. The problem with budget lines is that whereas it is able to ensure accountability for resources, it is fixed, it is not flexible. People are not able to repurpose funds. If you say you want to buy oxygen machine and before the money comes, somebody has already donated oxygen machines to you, you cannot use that money for something else. It will be violent and it is against civil service, against the public financial management policy and rules. So DFF is something that happens in Nigeria using the basic health provision funds. It's a whole story by itself, but it's something that's helped a lot of facilities improve in the way they deliver services. You also know about the Vulnerable Group Fund, something that is established within the National Health Insurance Act of 2022, something that has evolved in the landscape. Health insurance used to be voluntary and provided for in the Nigerian Health Insurance Scheme Act, but that act was repealed and replaced with the Nigerian Health Insurance Act of 2022. Which collaborates and complements actually the Health Act of 2014 that provided provided the Basic Healthcare Provision Fund. So in the Health Insurance Act, it refers to the BHCPF, but also refers to the Vulnerable Group Fund, where the NHIA is supposed to use this fund to then provide a basic minimum package of healthcare for Nigerians. The question is how this fund is going to be resourced and how it's going to be implemented and how the mandatory nature of the NHIA Act is going to be implemented. That is the next phase of evolution of the healthcare system. So we've moved from voluntary health insurance to mandatory health insurance by law. Now we're in the phase where we need to begin to think about how to implement the law and give life to that act. Of course, we know that BHCPF also provides for health emergencies and the NEMSAS program. And that, if you look within the ministry, you see a lot of buses that have been donated, procured. The idea is to have people have access to emergency care for healthcare services. Within the scope of this evolution of the healthcare space is, of course, focused hugely on a number of different issues that the minister and therefore Federal Ministry of Health is focused on trying to achieve. You will see such things as trying to save lives where we can. That means increasing life expectancy at birth. In order to be able to increase life expectancy, it means trying to do everything we can to ensure that adults don't die in currently 50-something years as Nigeria has it, and then move our life expectancy rates to those rates that are somewhere in the neighborhood of the 70, 60, 70 years of developing countries who invest more in in having humane societies, you would already tell that the causes of death are not always medical. They also include other sectors. We're fighting insurgency, we're fighting all sorts of things that take people's lives. So it's not just a health question, but there is a health component, and that means reducing maternal deaths, neonatal under 5 deaths. These deaths, the NDHS survey kept maternal mortality at 512, is it? Per 100,000 births. Such numbers are, not very good and need to be brought down. And then there is the intention to reduce physical pain. You see, if something doesn't kill you, it can impact on what we call morbid. It can lead to a morbid condition, deformities. Those are morbidities. When you have chronic diseases that lead to impairment of function. And that degree of impairment of function is measured by such things as quality adjusted life years, and DALYs, disability adjusted life years. In economic terms, basically you're trying to measure the quality of life an individual has remaining, due to some impairment of function. And of course, you have the intention to reduce the financial burden of trying to get healthcare, which popularly we measure out-of-pocket expenditure for. We measure out-of-pocket expenditure for health. And currently, Nigeria has out-of-pocket expenditure rates that are among the highest in the African space and globally, actually, over 70%. And these new investments in healthcare would, contribute greatly to managing them and reducing them. And in order, in fact, to all these monies we're discussing and the effect of them would be plowed into disease programs. Okay, and on the screen you would find a number of such identified areas of focus by the new ministerial directive. Now, in terms of financing and the monies and where they go to in health, the health space in Nigeria, I would speak to what we saw from our data sets from national health accounts for the latest edition is 2022. We're currently tidying up and trying to conclude those for 2023 and 2024. But for now, the latest information we have is for 2022. In 2022, about 9 trillion naira was spent in healthcare. That's about $21 billion in the health sector. A lot of money. This monies, in terms of our population, it was about $100, 99 point something dollars per capita. That means for every Nigerian, about $99 was spent on their health for an entire year. Now, it was an increase from what we had done over the previous years, but it is not new because every year it increases, but not as proportionate to the extent that we expect that increase to happen. Okay. Individual expenditure, however, which is really the problem, has stayed above 70%. You can see here, household expenditure is over 74%. Now, this is what government is spending. In financing, when you have household spending this much in healthcare, we take it as an indicator, actually a positive indicator to say that there is willingness to pay. So people are willing to spend money on healthcare, right? The question is, and that's the whole reason why you have some prepayment mechanisms. Insurance is one of it. To flip this 74% into some prepayment mechanisms which could be insurance, and so that people don't have to pay for this money when they are ill and when they are not able to afford it. Okay, but keep an eye on government expenditure. Government expenditure is somewhere around 14% total. So the argument in health financing space is that government has to do more. Okay, government really has to spend more. Government should be spending this 74%, while individuals are spending 14%. Now, importantly, is to note that all of the monies development partners bring and we spend is just 11 point something percent of total health expenditure. Not as significant, but the reason why they have a very prominent place is that they've chosen very strategic, tactical places to spend money on. They don't spend money on those things that you don't see. Salaries, building hospitals, and those things. They don't spend their money. They spend their monies on operations that we can relate with. Again, this is just a breakdown of how financing and where we spend those monies on. I won't dwell too much on it, but just to flag that there is also a pool of private sector that we don't often talk about that spends quite a bit of money on health. But overall, you can see that the household has the most of the money. And I wanted to also flag that development partners also spend money through government entities and agencies. It's not every time that they spend their money. This is important because of the swap conversations on trying to harness and have one budget for all of the health pooled funding, pooled financing. Government health expenditure is broken down as we see it here. Again, you will see households bearing a significant amount of it, but I just wanted to also just flag the fact that what we do in the NHIA is supposed to be a social health insurance scheme, but there's also that voluntary nature of it that doesn't have to do with the social nature. Social health insurance is contributory, where a government or an employer contributes and the worker contributes, right? The voluntary health insurance is the one that an individual, mirroring also private health insurance, just goes and says, I want to buy a healthcare package for insurance. Nobody's counter funding whatever it is that he has to produce. These here are where we spend money on. This is the landscape for health financing, right? You would see that malaria has the highest chunk of expenditure, 27% of total of all the major places where we spent money on in 2022, the accounting processes that we did, followed closely by reproductive health. And then you would find such things as HIV, AIDS, TB, and vaccine preventable diseases. That's the communicable diseases. Worthy of note is also to say that something that we see, in trying to pursue universal health coverage, we recognize that primary health care and preventive services are cheap and arguably the most cost-effective places you want to be able to invest money in. Because if you spend money in prevention and people don't get ill, you reduce the pressure in health facilities, you reduce the amount of monies that you would spend to treat potentially more severe conditions. And you then also manage the mega resources that are available by not spending them on potentially more severe conditions. What we find, however, in the Nigerian space is this red line tells you about healthcare expenditure that happens in primary healthcare services, and the green line shows the total primary healthcare expenditure. That means the difference between this line and this line indicates primary healthcare services that are rendered outside of the primary healthcare system. The question is, why are people not going to the primary healthcare centers to get primary healthcare services? I think you and I know what that answer is. But analysis like this tells us that a redistribution and reallocation of resources back from wherever it is that is happening, that probably will be private facilities, secondary health centers, tertiary health centers, teaching hospitals, are spending their time treating malaria, cough, and catarrh when they should not be doing that. And therefore, limiting the time that they would ordinarily use to treat more severe conditions. Analysis like this tell you what then needs to happen. Every year, we see the gap expanding more and more. People are just not going to the primary healthcare centers. Now, another thing I just want to flag with this slide is to show you we categorized spending in facilities. If you look at this facility, you see that most of the healthcare expenditure happened in secondary and tertiary healthcare centers, 40 something, nearly 50%. Nearly 50%. That shouldn't be. It should be the reverse. More health spending should be happening at the primary health centers, but only 7% of healthcare expenditure happen in primary healthcare centers. This is very instructive and tells us what we need to do. But let me show you something interesting. Look at this. Pharmacies and other providers of medical goods. So patent medicine stores, pharmacies, and such places, more Nigerians went there. More healthcare expenses, 19.3%, happened there than in primary healthcare centers. You can make your deductions for yourself on the landscape for financing. In terms of primary healthcare expenditure, we spent per capita $4.43 per capita, right, in primary healthcare. Excuse me. Out of the about almost 100 I told you about that we're spending per capita in primary health. Of this money, the one that came from government as domestic resources is only $2.6 per capita. So as a government, we're spending about $3, nearly almost $2, about $2.5, $2.50 on each Nigerian per year domestically. So this is what the minister refers to, and why when he mobilizes money, he speaks to this figure around the need to expand our sources of mobilizing resources. Now, apart from government resources, there are also other sources of fund. And in order for this evolving landscape for financing, we mapped resources coming from development partners for 2024, 2025, and 2026. And let's use 2024. 2025 data sets were collected in 2025, and therefore do not exactly, this picture with the US pooling resources and everything is not exactly clear. But just to give you an idea that, for instance, in 2024, we were able to map about 1.5 billion. Remember that I had told you that total health expenditure was in 20-something billion dollars. 1 point something billion of it came from donors. 2024, we saw that the largest donors bringing money to Nigeria, PEPFAR, Global Fund, USAID, Gavi. Remember that USAID and PEPFAR are the same US government. Remember also that Gavi and Global Fund are hugely funded by the same US government. So in summary, the US government is a huge financing partner for Nigeria and many other global institutions. And that is why the US funding pool becomes very impactful. But you can also then see that there are a number of other partners who fund the World Bank loans to Nigeria, EU, and other development partners. This is, just focusing on some other smaller donors that could not show up. $1 million, GIZ, UK Aid, Global Affairs Canada, CDC. So they donate something. So we accounted for everybody who brings money. Those who are bringing hundreds of millions and those who are just bringing millions. But what does this money go into? What did we see as a landscape for financing? How were they spending this money? You can see the legend here that shows you where they're spending the money on: health system strengthening, HIV, tuberculosis, health system strengthening is HIV, AIDS. HIV. So HIV significantly took a large chunk of the funding because of PEPFAR and the Global Fund. Malaria was 158, NTDs 1 million, immunization services, and the rest of them listed here for 2024. We're mapping those for 2025 as we speak, and we'll be able to also illustrate this. Again, this shows you across different programmatic areas how financing goes, and you see here programs that are just not even visible. But you would see the ATMs, as you can tell, and immunization are the largest contributors to funding. The other thing that we did is to also look at the geography of financing. Where were these monies spent? And our analysis showed what you see on your chart. You would see that Kano had, in absolute numbers, about $1 million spent in Kano. And however, Ogun State didn't get as much as Kano got. Now, it is important to state, however, that you see these red dots we have here. These are a calculation of, sorry, Kano got over, did I say 1 million? No, Kano got over about 16, 17 million US dollars, please. Whereas Ogun State got somewhere around, I think about 1 million or so. Now, the red dots you're seeing on each of these bar charts was an attempt of us to tell this story a little differently. You know, there's something about equity and equality in financing. Equality connotes where you treat people as equal, irrespective of social standing, irrespective of geography where they live. But in health, there is a very important concept of equity. You need to be responding. If disease endemicity is more in an area, you need to send more money there than you're sending to places that are better off. So we took these total numbers of money spent in each of these states and calculated per capita what it translates to per person. You will then see that Kano, Gombe State now became the largest recipient of monies per capita, and no more Kano. And you will then see that Lagos and Katsina, even Katsina got more money than Kano. You would also see that Niger, Jigawa also got more monies than Kano did, if you calculate per capita. This is important to balance out this conversation when states agitate for equality of financing. This basically just illustrates the same data I showed to you earlier on in just another in another way of showing it. Here we try to show what, when these monies go to these states, on what are they spent. If you take Kano State as an example, you will see that a significant, nearly 45% of that money goes to nutrition and nutrition services and health system strengthening issues. And then a small fraction of it goes to tuberculosis. When we comb down on this data further, we would see, other nuance, but these are the big spending items. Lagos State, the story is slightly different. You have a lot of public health emergency spending and preparedness issues in Lagos. And then, of course, you have HSS and you have malaria in Lagos. So we did this for all of these states, and you would then see, that is, remember, from data declared and reported to us. Now, in order to be able to manage all these resources, and
sorry, Dr. Uzuoma.
Yes.
Apologies. We'll need to wrap up so that we close this session.
These are my final slides.
Next 5 minutes.
These are my final slides. So in order to be able to manage this landscape that is evolving, and in order to harness all of the financing that comes from both government and from development partners, the ministry had then introduced the basket funding as we know it in other countries, and in Nigeria we call it the SWAP approach. And that connotes everybody, the entire sectors, planning as one unit, developing one budget, and developing a one report. Yesterday at the divisional meeting, we alluded to this one report and the need to enforce it. And that means having a uniform set of indicators, measuring the same thing and using those things to be able to make decisions. And it is on this note that we now have a landscape that is coordinated centrally, and states are also empowered to be able to coordinate activities centrally. The minister enforces and speaks about the fact that it is not enough for us to move towards harnessing all the financing resources so that they can be more effective and better utilized. but that it is important that they are aligned. He speaks, and I quote him, in a meeting in Health Financing Forum where he attended and spoke, and he said, aid alignment is not an end in itself, but a means to an end. This end being the improvement of population health. We have to ensure that actors behave differently to support the direction of government. And he went ahead to say that this drive for alignment with government's one plan, one budget, and one report, as indicated in the compact and sector-wide approach, will require both external alignment from development partners as well as internally from subnational governments. Thank you very much, colleagues, for listening. Happy to take questions. Apologies for the delay in beginning, but this is my final slide. Thank you.
All right. So thank you very much, Dr. Uzuoma, for giving us, walking us through the landscape of healthcare financing in Nigeria. I think you've made justice to that presentation. We'll quickly take comments or questions. I cannot see any. The Q&A session is completely empty. And also looking through the chats, I'm not sure there's any question. So colleagues, feel free to indicate by raise of hands if you have question. So we'll allow Antonia to speak. Please, you'll be a little brief as we are already running out of time. Please, let's make Antonia give her the opportunity to speak. Yes, please, Antonia. Please, you can go ahead, unmute. Let's have your comment or question. Please, direct to the point. Antonia, can you hear us, please? Can you please unmute yourself? Okay, I think she's having difficulty unmuting. We might take her comments. Maybe she will need to meet us in the office if possible, or reach out via WhatsApp. We're able to take her questions, if any. Thank you once again. Maybe we'll just wait till dots of time. Dr. Uzuoma, if you still have time, we still have 6 minutes. Yeah, so there's one of your slides before then where, let me, I think I remember the slide number. So I think there were issues with the aggregate health expenditure, where you have your, what number of slides? I can't say. So, but when you talked about the current expenditure, capital expenditure, then you have the total health expenditure. You said we spent over 9 trillion, but on your table, it is written amount in brackets, billions naira. So I think that's something we could just probably correct. Yeah, these slides. So the first table up there, you can see the headers, expenditure type, amounts. So under your amount, you're having in billions, but I guess your narrative for the part of naira should be in trillion. Sorry if you're speaking.
Can you hear me?
Yes, we can hear
Can
you.
you hear me? Okay, so no, so it's in billions of naira, but look at the figure. It's 8,000 billion. So if it were just 850, it will be 850 billion. But it is 8,000. This is already another 1,000. So this is actually 8.8 trillion. This is 342 billion. So it's just a legend issue. Do you understand?
Yeah, so how do we build that consistencies across that particular column?
It's consistent. So this is 342 billion. This is 8 trillion because 850 is billion and this part is trillion. When numbers are very big, right? If I write this in, if this is trillion, you would have had so many numbers here. So it's just a way of managing legends. Compare this and this, and maybe it might be clearer.
Yeah, it's actually clear. But when you have a table labeled, it means that every other thing that falls on that particular column should be in keeping with either in billion or consistent with in trillion. That's what I understand by table labeling.
Yeah, let me show you something else. Look at this. No, let me use. Anyway, I understand what you're saying, Eko, but this, where is that? Okay, I understand what you're saying. If, for instance, so this number is in trillion, this one is in billion, what would you say would be here? What should you put there if you were to do this legend?
I'll probably just leave it as amount, then put Naira in brackets.
So how would you, so that means you will now write, you will now write, you will write 8, 850, 000000000. Okay, I hear you. No worries. But
All right. No, it's fine. That's just on the lighter note. Once again, it's 10 a.m. from my time. We just to appreciate you, Dr. Zoma, for your time, for putting this together on a very short notice. We appreciate you. Please do well to share your slides so those who were not able to join the call can benefit. And then, if possible, we're going to also share the recordings of this call. So we would want to quickly, Dr. Bosse, please, is there any housekeeping, any announcements? If not, we'll see you guys in 2 weeks.
I want to join my voice to appreciate the head healthcare financing for educating us this morning. I'm sure everyone now knows what healthcare financing landscape, have an idea of what it is, and anybody in the department can use this information to say one or two things out there if there is need for it. And I want to encourage everyone to please try to prioritize this webinars. It's actually very informative and educative. I've learned a lot this morning. I want to encourage us to prioritize it, and anytime we'll call, it's 2 weekly, every 2 weeks, according to the director. He hasn't changed that. So, and also, I think the next division that will be giving us a webinar should be M&E. So we'll reach out to them to give us the topic and prepare. So in 2 weeks, we'll see you again. Thank you so much. Okay, there is a comment here by Bernard that you should label it as trillion or the legend that David was talking about. So thank you everyone for making our time to be on the call, and we wish you a very successful day.
Thank you everyone for listening. Thank you for the opportunity to present. I left this last slide up because it's arguably the most important thing. If you want to take anything away from this, just know this and everything about it, and you would already have become half a health financing expert.
All right, thank you, Dr. Zoma. Do well to transform the cubes to maybe some chocolates or financial benefit to our pockets. Thank you once again. And see you over and out.
Okay, thank you.